You all to today's session on a topic that is both timely and transformative, which is the role of artificial intelligence in depression management. Hi, I'm Dr. Anahita Ali, working as Associate Program Director of Public Health at James Lane Institute, Switzerland. We are thrilled to have you all join us as we explore how innovative technologies are reshaping the landscape of mental health care. Depression is one of the mental disorders which is quite prevalent and complex condition that affects millions worldwide. The World Health Organization estimates that 280 million people have depression, which is about 5% of the world's adult population. Unfortunately, more than 75% of the people living in low and middle income countries do not receive treatment for such mental conditions. Traditional methods of treatment, while effective for many, often face challenges related to accessibility, personalization, and timely intervention. And this is where artificial intelligence steps in, offering new avenues for understanding, diagnosing, and managing depression. Today, we will delve into various such AI applications and we will see how these tools can enhance patient care, improve accessibility, and provide real-time support. And for this, today we have an exceptional speaker, Dr. Farooq Alvi, who is a professor of health informatics at George Mason University, Virginia, United States. He is an operations researcher and industrial engineer. He has a wealth of experience in academia and the health industry. He holds various patents on sentiment analysis, illness measurement, and personalized medicine. His research focuses on causal analysis of electronic health records, contributing to predictive medicine, precision medicine, comparative effectiveness of medications, predicting prognosis for patients with multiple morbidities, and much more. He has also been a pioneer in online patient management and has published several books on decision analysis, policy systems, process improvement, and causal statistical analysis. So as we embark on this journey, I encourage each of you to engage actively. Please feel free to send in your questions in the chat box and we will take them one by one after this session. Thank you once again for being here. Let's get started and uncover the potential of artificial intelligence in transforming depression management. And with this, I would like to invite Dr. Alvi. Sir, the stage is yours. Thank you.
Thank you very much for that introduction. And my apologies for coming a little bit late to the meeting. I was under the impression that it was in the afternoon, but I think my time recording was wrong. But I'm here and I'm delighted to speak with you. Let me share my screen and start my presentation. So today I want to talk to you about the system for management of patients with major depressive disorders. I will talk mostly about our progress in this area, and at times I will also talk about some plans for the future and some features we want to add to our system. This work wasn't done by me alone. A large number of individuals participated in this work. A number of our students, as well as a large number of our faculty, In addition, we were funded by Commonwealth Health Research Board of Virginia, Robert Wood Johnson Foundation, Academy of Health, and Optum Labs in accomplishing these tasks. The current situation for management of patients with major depression is really unacceptable. The majority of the patients, not the minority, not a small percentage, but the majority of the patient receive medications that are not appropriate for them. That's not a situation that's tolerable. We need to rethink this. More than 60% of patients' first antidepressants are wrong. This is not something that I am claiming, but something that has been published and known since the initial NIMH funding on STAR-D studies. In addition, there is a large number of other issues. The fact that most studies show no difference in average among patients, but at the same time, we see that a lot of clinicians and patients are seeking to prescribe one medication after another to find a solution for them. And some, about a third of the patients eventually do find an antidepressant that works for them, showing that really not all antidepressants are the same for the same types of individuals. We did a study a while ago that showed that there are 16,700 different types of patients for which antidepressants can be prescribed, well beyond clinical capabilities. At the same time, there is also reports that most negative findings are not published and clinicians are not aware of them. There are also reports that unsuccessful antidepressants depend on comorbidities of patients, which are vast and beyond randomized clinical trials. So all of this has made a situation where patients' outcomes are truly unacceptable. So what to do about this? We analyzed a massive database of 10.2 million treatment outcomes that were medications that 3.6 million depressed patients had taken. And we identified what works and for whom. And that is the knowledge base on which our AI system is built on. Our findings so far shows that our predictive models are 17.5% more accurate than average clinicians. That is to say, if clinicians would prescribe as per our predictive models, 17.5% more of patients would benefit from their prescriptions than the current situation. Currently, around 40% benefit from the first prescription, and this will take it to 17.5% plus 40, so it would be 57.5%. Not fantastic, but still better than the current situation. So our analysis showed that approximately 1,499 medical history events are relevant in deciding which antidepressant is best. This is well beyond human capabilities to take into account. things like what procedures you have had in the past, what diagnosis you have, what age you are in, what experiences you have had with antidepressants, all of which affect your next antidepressant prescription. It creates a very difficult situation because obviously we can't ask in the intake from medical history, we can't just go ask the patient, do you have this condition? Do you have this procedure in your medical history? Asking 1,499 questions from patients is torturous, too time consuming. So a solution needed to be found. One approach is to not ask all the questions, just ask what are the major predictors of antidepressants, create a tree structure, and as people answer, limit the additional questions that are relevant. So ask for about the age first, and then ask about questions that are relevant for the age of the patient, then ask about procedures that are relevant in that age group, and so on. And we have developed a system that you can actually go and use. It's available at on the web at meagainmeds.com, and you could use that on your phone to find out which antidepressant is reasonable. Again, before you start using this, I caution you that this is still experimental and we are working on improving things. Me Again Meds, the name comes from the fact that we want to make sure that we appeal to depressed patients. And one of the complaints of depressed patients is that when they take antidepressants, they are no longer themselves. So we came up with this name so that we will help them find better solutions for them. This obviously, this approach of looking at only major predictors of antidepressant works, but it's not very accurate. We're giving up accuracy for the purpose of making it easier for the intake. A different solution was needed. And the solution we adopted was to use language models and ask open questions. Now, the way we have organized our system is very unusual because when you go and you hear about AI systems, language model, large language models, you're often surprised. I am often surprised when I see that they are actually not clinical tasks. They are mostly administrative back tasks for hospitals or for clinics. They are not directly addressing the problems of the patient and the outcomes, and they are not working on that. This is an application where we are working directly with patient outcomes, and we are going after the core clinical activities of a clinician, which is taking medical history and deciding which antidepressant, which treatment is best for the patient. That's what we're trying to do. We are not trying to solve an administrative issue, and therefore our approaches are very sensitive to how these interactions should occur, and we think we have made progress in this area. So we use the large language models only in the intake, but not in giving advice. There is a number of reasons for that, and I'll go over that in a moment. We only think about the situation here. We have a person coming and expressing their conditions, their history. Obviously, that person talks in a language, and preferably in English for our systems, but our systems can also work in other languages. This person is saying words and might forget to say some things, or might not recall his history accurately, but at the same time will remember things that are not in the electronic health record, because most electronic health records are fractured across different clinics and different physicians, and therefore might be more complete. But even if he's not complete, it's important to understand how we can anticipate things that the person might not say. How could we read between the lines and know what the person hasn't said but is likely to have? Then once that's done, we want to predict which antidepressant is best. And that is a very precise prediction for which large language models have no training. Because in these kinds of predictions, you're looking at data, not text, not language. And you're looking at massive data. And you want to then predict what response to treatment would be. So here is an example. This is a prediction made by our system on 15 different antidepressants. For this patient, the antidepressant venlafaxine has 57% response rate. Sertraline has 51% response rate. Trazodone has 1.7% response rate. And you can see how it is really different for different patients. And as the age of the patient changes, as the conditions of the patient changes, the predictions all change. This model, this predictive model, is derived from a chain of high-dimensional regressions. What that means is that for each one of these antidepressants, we have a Lasso regression model, and these have hundreds, sometimes 300, sometimes 200 variables that predict the response rate. And they are different. So for sertraline, we have a certain number of predictors. For venlafaxine, we have a certain number of predictors. As the language model collects what information is relevant, these predictive models' probabilities change, and the advice to the patient changes. But it's true that these predictive models can give advice, and it's unique in our organization of the architecture of our AI system that we are separating language from predictive models. And there are advantages to that. The main advantage is that the hallucination that occurs in AI models does not occur in predictive models, and generative text are not needed in the predictive models. There are all preset texts. So we reduce the frequency of hallucination. But the other advantage is that predictive models are far more accurate far more accurate than language model, because they rely on a larger data set. So far, we know from large language models that they have tried to capture all the text on the internet, in the books, and so on. But predictive models go somewhere else for their source of information. They go to data, And there are large databases available on treatment effectiveness. And those are not currently part of large language models. So we need to marry these two together before we can proceed in a system that helps the patient. So here is an example of the initial view of our large language model data collection. So a chatbot comes on, it says, I'm a chatbot. It asks them, do you have major depression? And it verifies that you don't have major depression. I mean, that you do have major depression, but you don't have bipolar depression. And after that, it verifies, it asks open-ended questions like, what is your current medication? What experiences you have had with previous antidepressants? And the patient respond to these in their own words, and the chatbot understands the variables that are important for predicting response to treatment. But it doesn't predict the response to treatment. It just collects the language, collects the variables, and then waits for a predictive model to kick in. The beauty of the intake like this is that we don't need to ask 1,499 questions to verify what the patient has. We just need to ask questions about what they do have, and we don't need to ask about things that they don't have. The patient himself is telling about their history, and is telling what they have. They can't even talk about what they don't have. So how do we link the language model to the predictive model? This is a real complicated issue because predictive models are optimized for a certain set of variables combined together. And language models collect only a portion of the variables that are needed. So the patient reports their medical history, and some of the variables that are required by the language model are reported by the patient. But most often, what is reported by the patient does not match what is needed by the predictive model. So no actionable AI can actually function here. So we needed to solve this, and we have a patent pending procedure that we put into place. Basically, this procedure uses the patient-reported medical history to predict variables that they haven't reported, and then predict all of the items in the minimum required data. That requires a chain of lasso regressions to capture the joint distribution of the variables and predict from variables that are reported, variables that are unreported. But once that's done, then we have the minimum requirements for actionable AI to take charge. There is another problem with AI systems, and that is that patient safety is a problem because patient may come to the system and they might tell to the system that they are going to commit suicide, or they might digress, they might go and talk about a movie they have seen. They may say things about their family, but no longer participating in a intake that is goal-oriented and has to collect a certain number of information from the patient before it can proceed. So those kind of digression makes things very difficult for us. In order to address that, we have created another AI system that monitors our current AI system. And it sees every interaction with the patient. We call this other AI system the dialogue management system. This dialogue management system looks at the interactions between the patient and the AI and sees if they have digressed and sees if they have said things about suicide, and then takes different kinds of actions. At every turn, the AI system is told new prompts and new context by the dialogue management system. So the dialogue management system says, oh, we are right now in the context of collecting whether the patient has bipolar depression. And your instruction is to ask if the patient has bipolar depression. Then the AI system goes and asks that question in the words that the AI generates on its own. And then the patient might say something that's unusual, which, for example, the patient might say, what is it? What is bipolar depression? Then the dialogue management system says, oh, that's in topic. That's not out of topic. So instructs the AI system to answer that question. Or the patient might say, I am going to commit suicide, or I have bought a gun. Then the dialogue management system says, wait a moment, this is a risk factor for suicide. So I need to transfer this conversation to a clinician or to a designated individual that the patient has consented at the beginning to inform. So in this manner, the dialogue management system is really controlling what kind of adverse events might happen, or how digression happens, and how certain digressions are allowed. This is an overview of how the dialogue management reviews its input. The dialogue management works off of a topic network. The topic network is derived from the knowledge base of the AI system. Again, there are papers on this. I can share it with you. Basically, what we do, we take the prompts and completions in an AI knowledge base, and we regress completions on the knowledge base, on the prompts, and identify what a network structure inside the knowledge base that creates the topic network. This is a very broad topic network. So we start with the age of the patient. We ask about depression type. We ask about history of psychotherapy. We go to prior use of antidepressants. We ask about current medications. We ask about comorbidities and other illnesses. And then we make our advice. But there are many, many digressions, many, many different steps we take during this dialogue management. And so, for example, if prior use of antidepressant tells us that the person is treatment resistant, we might quickly go to our advice. Or if the person depression type is bipolar, we can say to them, oh, we are not ready to give you advice on bipolar depression. We have to work with major depression, and so on and so on. Behind each one of these nodes, there are hundreds of other topics that are allowed. So this way, the dialogue management understands what topics are allowed, and they can understand to what extent digression is happening, to what extent the patient is responding to the questions, and to what extent the patient is reporting something else that is important still to be addressed, but maybe not by the machine. Even though we have the dialogue management system, we are not happy with it. Well, we're not happy with it. We are not sure of it. So we want to have more certainty till we have more experience in managing patients in this manner. And for that purpose, we have created a real-time human-in-the-loop monitoring. I shouldn't say we have created, we are in the process of creating a real-time human-in-the-loop monitoring. This human-in-the-loop monitoring works in this fashion. Every interaction is mirrored to a website where a third party, usually a third party suggested by the patient, not in the location of the patient, can monitor the interaction. And we train this third party to also monitor the AI and say, AI is digressing, or AI is saying irrelevant things, or the patient is saying suicidal things. And at every turn, this monitor can stop the interaction and transfer the conversation to a clinician on our staff, or to an individual that the patient has identified at the time of consent that will agree to receive referrals like this. Now, this kind of real-time monitoring seems not at scale. So in order to create a scale where we can deal with hundreds or thousands of people at the same time, we can't rely on in-house clinicians all the time. We have to rely on these third parties that the patient specifies for monitors. And therefore, that's one feature that we are working on how do you actually train this person, and how do you monitor that they are actually doing their monitoring. One thing I should mention is that when the patient is not suicidal, the default action is continue. And that default action works after a certain period of time has passed and the monitor has not responded. But when the patient is suicidal, the default action is stop. So it requires the monitor to actually respond before the patient goes on to the next stage. So this manipulation of the default action is one feature that helps us operate more efficiently. So one of the things that we have done also is automated detection of suicide risk. We now can monitor conversations, and we have looked at accuracy of ChatGPT doing so. And surprisingly, ChatGPT is very accurate in monitoring suicide risks. We identified 15 different suicide risks from the Columbia Suicide Risk Index, as well as from other indices. And we were able to see in 58 dialogues that actually ChatGPT identified the same number of the same risk factors that a human being was identifying. 97% of time, the human being and the ChatGPT were in agreement on what risk factors was present. These are things like I have the means for suicide, or I have the client has thwarted belongingness. For example, in a conversation, a person may say that they are gay and that they have been outed on the web and they are nervous about it. That is a measure that ChatGPT could understand that this belongs to thwarted belongingness and reports this as a risk factor for suicide. There is also a concern that our approaches to predicting response to antidepressant might have algorithm bias. So we have been working on removing algorithm bias, and we have succeeded in doing so for African Americans, and we can do more for Hispanics and for LGBTQ patients and other subgroups of individuals. Our approach is quite interesting, and I like to highlight some of it. What we do, we predict the accurate, we use the population-wide race-blind models, and we predicted in subgroups of patients, in this case, African Americans, and see how accurate it is. So if you look at here, for example, we see that amitriptyline is really not good for either one of them. I hope you see my arrow. It's not, 5% McFadden R squared is low accuracy. 10% for bupropion is high accuracy. And we see that there is no difference from a model that is specific to African Americans to a model that is population-wide and race-blind. Citalopram, we see that the race-blind model is actually more accurate, and so on and so on. But we see sometimes that for nortriptyline, the race-specific model is way more accurate, and therefore we need to correct our algorithm to use for African Americans the race-specific model in this antidepressant. The same occurs in escitalopram here in the middle left here, that we see that the race-specific model is more accurate. This kind of comparisons is called hierarchical regression modeling, and McFadden R squares between 10% to 20% indicate excellent prediction accuracy and good prediction accuracy, and McFadden R squares above 20% are excellent. These are not the same as percentage of cases correctly classified, but it's different. So this shows you that we are making progress in fitting our algorithms, our predictive models to specific subgroups' needs. And again, it highlights that there are sometimes changes necessary to a generalized population-wide algorithm. We still have to do the work for Hispanics and other subgroups. We try to see what is the interest of patients in receiving our advice. Now, remember, our advice is based on online intake. So patients can actually participate in this intake at home. So they are not necessarily in a clinic. So we could easily advertise and recruit these patients through advertisement. And one of the things that we observed was that only a third of patients who are African American and depressed are in clinics. The vast majority of African Americans have abandoned treatment of depression. They are outside of the clinics and they're not seeking any longer treatment for their depression. By advertising, we can reach African Americans, we can reach Hispanics, we can reach all the subgroups, all the minorities, as well as white patients who are no longer in treatment or who are in treatment but are receiving poor symptom reduction. They can all participate in this. So recruitment online is really important. And it is a different way of providing AI services. It's not through clinics. It's a different vision for the delivery system, that the patient receives the information first before the clinician receives it. In a way, it's preferred by the clinician because this AI intake takes a long time. It takes 5 to 10 minutes just for the intake. Doing so inside a busy clinic is really problematic. By doing it at home with the patient, they will prefer it. And then referring the patient to the clinician works really well. Clinicians always are interested in referrals, even if it is by AI or not AI, they are always open to referrals. One of the things that was surprising to us was the number of patients that responded to our advertisement. More than 1,500 patients came to our site in the 2-week period that we were advertising to Northern Virginia depressed patients. And these kind of advertisements were not very costly for us. $3.84 per click-through is not enormous money to actually find individuals that are depressed and refer them to proper treatment. We also were wondering if clinicians like to receive our services. So we went to LinkedIn and identified a large number of psych mental health nurse practitioners and asked them if they would be willing to receive referrals from our system. And 52 of them said yes. And this was again done in a month's time. Very simple, just asking clinicians if you would want to receive these. Later on, we actually entered into contracts with 4 of them to actually refer patients to them, all of which seems extraordinary to me, because here is an AI system that we are in the throes of development, and people are lining up to sign up and receive referrals for it. Patients are lining up to actually go through it and see the experience of it. So while the psych mental health nurse practitioners were very open to our referrals, the psychiatrists were less open because their clinics are much busier and they have less need for referrals, and they wanted to have more studies done. We are in the process of doing additional studies, including prospective studies, but I think at some point we have to stop doing studies for the sake of additional studies to convince a few people and start addressing the situation that patients find themselves where they don't receive the appropriate treatment. Recall that more than 60% of patients receive the wrong medication. So what are we doing with prospective study? The prospective study is a randomized trial, and it is not pragmatic, and it cannot address the accuracy of knowledge base. We are doing separate studies for accuracy of the knowledge base and the advice, because you can't do a randomized trial with its limited inclusion and exclusion variables in this fashion. So our prospective study starts with an online advertisement, gets consent, puts the patients through a baseline interview, and then they are randomized either to our AI system or to the Texas guidelines. And once that has occurred, they are referred to for appointment to either their own primary care provider or a clinic that's participating, in our services. And once they have gone to the clinic visits, the patients are contacted again and followed for 4 months, and they are interviewed about their symptoms. And we are trying to estimate the days that they are depression free, and we are hypothesizing that clinicians that follow our advice will have a larger number of depression free days for their patients. So, where are we? What are we doing? Let's just take a overview of this. We are trying to create an autonomous, safe, conversational, more accurate than clinicians, and free AI system for behavioral care. And we are in the process of pulling it together with bits and pieces of putting language models, predictive models, human in the loop, safety considerations, all into one mix so that we can accurately create this autonomous delivery system that will work online and provide patients with better advice. That's my presentation. I hope I am in the time allotted to me, and could take. What is the next? What do you want me to do next?
Thank you, sir, for your session. It was quite insightful and interesting to know that what you are doing in this field. And taking up a few queries from our attendees, let me ask one question that was posted by Robertson. And the question is, what are the examples of databases you utilized to access treatment effectiveness data?
Okay. Let me stop sharing so that I can be more helpful. How do you do stop sharing? Entire screen is shared. Am I sharing or am I not sharing?
Yes, sir, your screen is still visible to us.
Okay. Okay, stop sharing. Okay. First of all, that's a very good question. The question is, what are databases that are available? I recommend to you first, what we relied on was insurance data, and those are what some of the largest insurance data are available through Medicare. We relied on Optum Health insurance data, which is one of the biggest insurers in the United States. And we had a massive data on treatment and on the conditions of the patients. But there are also other smaller data available through National Institute of Mental Health. They have created a data repository that is freely available, and you can just sign in and collect and have access to that. That data repository has a lot of information on different kinds of things, including psychiatric treatment outcomes and bipolar treatment outcomes, things that we haven't paid attention to, that you all want to do more of. I hope that was helpful.
Yes, thank you.
Thank you, sir. Robertson, do you want to say anything?
I think he just said thank you.
No, thank you. I think, yeah, the answer was really clear. Now, just really quickly, I don't know if I can, Another question I had was based on your presentation towards the end. Are there medical apps of this sort that are more general, let's say less specific than yours, where it goes directly into depression? Are there some that are a bit more general? Also, if they exist, are they less accurate or more? But I'm assuming the second question is less because it's a little bit more general, but I don't know. What do you think?
Are they language models used to do more general things than just major depression? Is that the question?
Yes, basically.
Yeah. So language models that are currently, that I have seen reports of, almost none of them are focused on clinical settings or clinical advice. All the language models that I have seen so far are focused on back room analysis of data or on consumer, fitting the consumer to the needs of the clinic, or on marketing, or on our other aspects of healthcare delivery. They are not clinical like this one. There are many predictive models in the field, and they are all clinical. But there is no language model that is trying to do so yet reported in PubMed or in published literature. I'm not aware of it. So in a sense, you can imagine there is reason for that. And the reason is that it's so hard. Look at all the safety things that we had to do to just manage one patient through major depression. And to do that for everything possible, for psychiatric, for bipolar, for it's just too much. Now, there are a large number of possibilities. There are, for example, one could use what's in PubMed, published literature, and use language models to report published reports of different treatments. Those kinds of more general treatment reports work. They tell to the patient what article is relevant. So, for example, if you go now to some of these language model for analysis of literature, they can tell you, yes, there is a paper on effectiveness of antidepressant that discusses whether a patient, what should be done for a patient that is psychiatric. Those kinds of things work, but they don't tailor to the specific characteristics of the patient. Because imagine a published paper doesn't say for this kind of patient you should do BA, for this type of patient you should do B. It's more generalized. And those kind of advice, you can still get that. Essentially, it's a search in PubMed, but it's a well-informed search, and it works to get you going to the better information. But it doesn't tailor the treatment to you, and doesn't have the precision of predictive models. What I think our progress has been is to take predictive models and tie it to language model in a way that can make clinical sense. Predictive models have been, for at least the last 2 decades, been done for clinical settings. There are many good predictive models for clinical decisions, but tying it to the language models is the novelty that we have made progress. And I think if you guys do more of that, you will see more AI systems that are both accurate and can do that.
Thank you.
Thanks, Robert.
All right, so we have another question from Jean Morris, and it is related to the expense, basically the cost of this technology, whether human real-time monitoring can make it an expensive technology to use or not?
Well, that's a very good question. And this is the second time I have given this talk, and that same question has come up. What is the cost of software? Software is really, you can duplicate software and start using it. There's really not much of a cost. And what is the cost of delivering the advice directly to the patient? Again, you don't have buildings, you don't have uh, capital requirements of major costs like that. So once the software is developed, a lot can be done at a lower cost. Now, one question remains, and that is, can we scale human monitoring so it can be done more costly? Not more costly, less costly. Yes, we think we can do that. And the way we are trying to do that is by engaging a third party. So when the patient comes to us, they have to consent to our procedures. And one of the elements of the consent is that they have to specify a third party who would monitor their interaction with the system. This third party is somebody they have to contact and make sure that they are willing to do so. They can't continue with our AI system or even enter our AI system without identifying this third party. That third party has no cost to us. I mean, there is a cost to us because we have to send the text to them. They have to be trained very quickly, all of that. But that is minor cost that we are not actually paying for this third party to do things for us. So again, I think our solution would be scalable and at a low cost. We haven't verified that, but watch us in the next year and see if we can accomplish that.
Right. Thank you, sir. Next question is that can we consider it as a medical device? Can we call it as a medical device?
So FDA has two different procedures for deciding if a decision aid is a medical device and needs to go through FDA approval. One of the procedures is very short, takes around 4 months for approval, and the other one is very long, takes around 4 or 5 years for approval. The short one requires that the clinicians monitor the interaction and verify that the system is operating properly and the advice is proper. So our monitor human in the loop has the advantage that fits with the FDA's short approval process. We are in the process of asking FDA if they would approve this. It takes a while to prepare the application, but if they do approve it, we will be very happy because then we can proceed with our patient intake. But so to answer your question, yes, anything that helps the patient choose a treatment is required by law to be approved by FDA and is a medical device.
All right. Thank you, sir. Our next question is, what are the ethical considerations in using this technology for depression management?
Well, what are the ethical considerations? I wish Well, I have to ask the person who asked the question, what are the ethical considerations for prescribing to patients medications that don't work? To me, it's criminal what is happening to these depressed patients. It is barbaric. So, is there an ethical consideration to what we are doing? Maybe there is some consideration about maybe patients want interaction with their clinicians, but their clinicians are failing them. And the AI system is a solution for them, a solution that's not possible in the current clinical practices. So I feel comfortable that even if there are some ethical issues about empathy or about depressed patients being in a place in their life that they are weak and the AI is imposing on them, all kinds of different things that people have criticized AI systems for. In this situation, where clinical care is failing patients, I don't see any problem with a better system that helps patients do better. Now, I got to mention a few things. Research studies show that patients perceive AI to be more empathetic in question and answers than clinicians. And again, I underline this, more empathetic, more in tune with what the patient is saying than a human being, a clinician interacting with them. Now, that's not the same as taking care of them entirely through these kinds of systems, but it is part of the equation.
Okay. The next question is, how can AI be used to manage moderate depression?
Right. So moderate depression doesn't need antidepressants. Exercise and other activities, psychotherapy might be more useful for patients with moderate depression. And one of the things that we are doing with our system is that when we verify the patient's major depression, if the patient is in a certain categories, we do not recommend antidepressants to them. We actually recommend other kinds of activities. Now, the other side of this is severe depression. For some patients that have severe depression, we have no recommendations for antidepressants, and we recommend them to actually go through interventional therapy like ketamine and other kinds of depression treatment that are more modern. By the way, even though I am talking about depression treatment, I am not a clinician. I am an engineer. And my perspective comes from an engineer's perspective that healthcare should work. It's like if you go buy a car and 60% of time the car doesn't move. Well, that's not good. You need to have a system that works. And that's what I am trying to accomplish. Go ahead, Anahita.
All right, sir. So probably, I hope this is the last question from one of our attendees. And this is regarding a real patient perspective, a concern basically where a physician will use visual contacts in addition to what patient says to diagnose the mental health disorder or such condition. And those patients also, oftentimes have other psychiatric disorders that can interfere with the history that they give. So how AI technology can address such important issues?
Yeah. First of all, I should mention that visual intake is also possible by machines, although we don't use that. Second, I should mention that we could also rely on blue button features which collect data from medical records of the patient and enhance it with patient self-report. And third, I should mention that you're right. Humans can take on different kinds of information that machines can. But wait a moment. Our data and data of others shows that humans, clinicians, are really not doing a good job at this. So the information they are relying on is not important. So you go to a clinician and you say, you look very depressed, and the clinician says, well, you take this antidepressant. That's not good enough. That's not how care should be. So to answer your question more directly, yes, maybe other factors are important, but we have found that these are the factors that actually improve care. And so far, those are the factors we have taken into account. I look forward to receiving comments and questions from you privately on my email, and I would respond to it. And I think I'm very excited that you were here listening to me, and maybe you can lead this effort further.
Thank you so much, sir. I hope that everyone has found this session insightful, and also that all our attendees would take away some valuable information that can be applied in their practice. So as we come to close this event, I want to give, sorry. So as we come here to close this event, I want to thank our attendees and our guest speaker. I really appreciate your time and the effort that you have dedicated today for this event. And with this, I would like to call it a day and have a good day, good evening, whatever it is at your location. So please be connected for such further events. And I'm going to share the email ID, the official email ID of our speaker with all the attendees so that you can contact him directly, and you can send him email, and you can send your queries regarding this AI technology use and tool. So thank you all. Thank you, sir. Thank you so much for your time.